I want you to imagine something for a second. Imagine a city that is experiencing a just a severe, unprecedented drought.
Right, a total crisis.
Exactly. And the city has a single limited reservoir of water remaining. That's it. So the question for you, as the person in charge, is how do you distribute it?
Oh, man. That's a nightmare scenario.
It really is. Do you, divide it equally by the number of houses, completely ignoring how many people actually live in each house?
Yeah.
Or, do you give it to the thirstiest people first, even if they might need so much that others get absolutely none?
Right, or maybe you give it to the farmers, right, with the logic that, well, they'll use it to grow food that will eventually feed everybody.
Yeah, exactly. Or do you spend your precious dwindling water budget trying to fix the upstream leaks in the pipes so you just stop losing water in the first place?
The wild thing is every single one of those choices is entirely logical. I mean, you can build a really robust, morally defensible argument for any of them.
But every single choice leaves someone, somewhere, in very real danger.
Yeah, it is just the ultimate administrative nightmare.
And, that water reservoir, that's a metaphor for healthcare resources.
Yeah.
The agonizing decision-making process we just walked through, that is the very essence of health needs assessment.
It really is.
So welcome to our deep dive. I'm your host and joined by our resident expert. Our mission today is to completely dismantle the illusion that allocating health resources is just a simple, straightforward math problem.
Because it is definitely not.
Yeah.
We're going to bridge epidemiology, economics, and ethics to truly understand how populations' needs are measured, how they're prioritized, and ultimately how they are translated into equitable health policy.
So we have a pretty significant trajectory ahead of us. We'll be using Chapter 11.1 of the Oxford textbook of Global Public Health as our structural spine today.
Yeah.
So if you're studying this, read along with us.
Yeah, we're going to start with the really practical epidemiological mechanics of assessing need. The raw data, the surveillance, the numbers.
Right. And then from there.
From there, we will move into the frankly ruthless mathematics of health economics. And finally, we're going to tackle the deep, often really uncomfortable philosophical questions of justice, equity, and human capability.
Okay, let's unpack this. Because on the surface, the idea of health needs assessment seems, easy. You just measure health, you assess the need, and you orient your services accordingly.
Yeah, it sounds like a neat little tool for tackling inequalities, but need is a wildly slippery concept.
It really is. So let's start with the practical epidemiological approach. This is the camp that focuses on subsets of populations in really precise measurement, right?
Exactly. It's the approach built entirely on quantification, and it relies really heavily on existing routine data sources.
Because generating new primary research for every single local decision would just be far too slow, right?
Oh, yeah, and staggeringly expensive. So public health officials look at what is already there, and the very first step in this practical approach is just problem definition.
Right. You have to ask, why is this assessment needed right now? And who is actually going to be affected?
Yeah. And, my favorite question to ask in any strategic meeting is always, what happens if we just do nothing?
Yes. That do-nothing baseline is critical. If we don't intervene, does the problem resolve naturally? Does it escalate exponentially?
Precisely. Once you establish that baseline, you move into the real core of the epidemiological assessment. This is where we encounter the denominator imperative.
The denominator imperative. Okay, break that down for us. What does that actually mean when we're looking at a population?
So in epidemiology, we rely on two main measures of disease frequency. The first is incidence, which is the number of newly diagnosed cases of a disease in a given time period.
Okay, incidence is new cases. Got it.
And the second is prevalence, which is the total number of cases of a disease existing in a population at a specific point in time.
Right, so new versus existing.
Exactly. But here is the catch. Those numbers, the incidence and the prevalence, they are just floating, basically meaningless data points if you do not know the exact population base they are drawn from.
So that base is your denominator.
You got it.
Let me put a real-world scenario to that for you. If I tell you, hey, we have 100 cases of a highly infectious respiratory virus, that sounds alarming.
Very alarming.
But if the denominator, the total population of that specific community is only 200 people, we're looking at a 50% infection rate. That is a catastrophic public health emergency requiring immediate lockdown and triage.
Absolutely. But on the flip side, if the denominator is 2 million people in a massive metropolitan area, 100 cases is a completely different scenario.
It might just require standard surveillance. Nothing too crazy.
Exactly. Without defining that precise denominator population, you simply cannot accurately calculate or interpret your incidence and prevalence rates. A numerator without a denominator is just a scare tactic. It's not public health data.
That makes total sense. And I guess this brings us to demographic profiling. You can't just count heads. You have to build the really intricate details of the population structure into your needs assessment.
Yeah, we are talking about factoring in variables like age, ethnicity, occupation, and geography.
For instance, if you are conducting an assessment in a population with a significant demographic of Afro-Caribbean descent, screening and treatment for sickle cell disease might become a primary structural focus of your health system.
Exactly. Or alternatively, if you're looking at a traditional mining community or an area with really heavy industrial manufacturing, chest diseases, respiratory conditions, occupational hazards, those are going to command your attention.
So you have to intimately know who makes up your denominator.
You really do. This profiling allows you to move beyond abstract numbers. You start calculating the absolute number of people suffering from a condition and, crucially, the degree of severity.
And you're also analyzing risk factors, right? Like, what are the local levels of smoking? What is the average physical activity? What does alcohol consumption look like?
Yeah, you are layering all of this data to build a really comprehensive, multidimensional picture of the burden of disease in that specific denominator.
So let's play this out. We have our denominator, we have our incidence and prevalence rates, we know the demographic profile inside and out, and we have identified a clear, quantifiable problem.
Okay, so the next logical step is figuring out what to do about it, because it really doesn't make any sense to assess a health need if we do not have a proven way to actually treat it or prevent it.
Which introduces the hierarchy of evidence. In public health, there are just countless interventions competing for funding.
Oh, absolutely. Everyone wants their program funded.
Right, so if we want to be certain that a specific medicine or a surgical procedure or, I don't know, a community health program is actually causing the improvement we want to see, we have to ruthlessly eliminate bias from our decision-making.
And at the very pinnacle of this evidence hierarchy, we have randomized controlled trials, or RCTs, and the massive meta-analyses of those trials, like Cochrane reviews.
So why are RCTs the gold standard here?
Well, they're deliberately engineered to minimize potential biases. By randomizing who gets the intervention and who gets the placebo or standard care, the observed size of the effect can be confidently attributed to the intervention itself.
So you essentially eliminate confounding factors.
Exactly. But for a local public health director conducting a needs assessment, digging through raw primary RCT data is just impossible. It is way too time-consuming.
Oh, nobody has time for that on the ground.
Right, so they rely on pre-appraised, synthesized evidence, like those Cochrane reviews, or guidance from centralized bodies like the National Institute for Health and Care Excellence in the UK. This rigorous filtering process is known as health technology assessment.
Wait, I'm going to stop you there, because something just isn't adding up for me.
Okay, what's missing?
Let's say we have perfect demographic data. We know the precise prevalence of a debilitating joint condition in our aging denominator. And we have a sparkling new Cochrane review telling us exactly which surgical intervention or new biologic drug is the absolute most effective at treating it.
Okay, perfect scenario.
Right, so we have the data, we know it works. Why is there a debate? Why can't we just deploy the treatment to everyone who needs it?
Well, you are hitting the fundamental wall of all health systems worldwide. It is the collision of finite resources with infinite demand.
Infinite demand. I mean, that sounds like an exaggeration. Surely there's a cap on how much healthcare people actually need.
You'd think so, but not in reality. Health systems are incredibly complex socio-technical arrangements. They're woven from people, cultural expectations, vast organizational structures, and staggering technological costs.
So you just cannot possibly fulfill every biological need or adopt every single newly developed drug.
You can't. And here is the paradox that really catches people off guard. Expectations do not plateau, they rise. People understandably feel entitled to the absolute best, most up-to-date, most effective treatments available.
Oh, wow. So the mere availability of a new medical technology actually generates its own demand. I see. So by simply inventing a new, highly effective pacemaker or a breakthrough cancer drug, we aren't just curing people. We are instantly creating a massive new financial and logistical strain on the system because suddenly everyone who qualifies expects to receive it.
Yeah, the invention itself creates the expectation, and expectations cost money.
So while new technologies are constantly emerging, The populations themselves are changing too. They're aging, they're dealing with more complex multimorbidities.
Right. You cannot simply deploy every effective treatment everywhere simultaneously. You are forced to prioritize.
Which brings us to the culmination of this entire epidemiological process, the case for change document.
Yes, this is where the public health official has to synthesize all of this overwhelming complexity.
So they take the local epidemiology, the effectiveness data from those RCTs, the cost-effectiveness evidence, and often the messiest part, the desires and demands of the local stakeholders and the community.
Exactly. They compare their local data with neighboring regions to see where they are lagging, and they build costed options to force a reallocation of resources.
Because the whole point of the epidemiological approach was to replace unmanaged, historical, and often deeply unfair distributions of resources where funding just went to the loudest voices or the most prestigious hospitals with something rational, objective, and systematic.
That's the dream, anyway.
So, we have built our epidemiological case for change. We know the problem, we know the evidence-based solution, and we know we have to prioritize. But how do we actually decide what gets funded and what gets cut?
Well, that brings us to the economics of scarcity.
Right, because if epidemiology defines the biological need, health economics attempts to solve the brutal math problem of scarcity.
And to truly understand the mindset of health economics, we have to look back to the philosopher Jeremy Bentham.
Ah, Bentham, the father of utilitarianism. For anyone unfamiliar, this is the ethical theory proposing that the proper course of action is always the one that maximizes utility.
And utility is generally defined as the greatest happiness or the greatest good for the greatest number of people.
Utilitarianism really serves as the ethical engine driving modern health economics. But to understand how Bentham thought about structuring society to achieve this maximum utility, we have to consider his concept of the panopticon.
Yes, the panopticon is one of the most fascinating and terrifying concepts in architecture.
It really is. Picture a circular prison. The inmates' cells are arranged around the outer wall, all facing inward. In the very center of the circle is a single watchtower.
And the brilliant, chilling trick of the panopticon is the lighting. The guard in the central tower can see into any cell at any given moment, but the prisoners can never see the guard.
So they have absolutely no idea if they're being watched or not.
Exactly. The theory was that because the prisoners might be under surveillance at any exact second, they will begin to police their own behavior. The mere threat of omnipresent surveillance enforces conformity and order.
Which is an incredibly efficient way to run a prison. But how on earth does an 18th century prison design relate to modern health needs assessment?
It illustrates Bentham's profound belief in maximizing social good and common harmony through highly rational, systematic, and often rigid structures.
So utilitarianism in resource allocation is about organizing the health system to produce the maximum common good, the most health for the most people, using the least amount of resources.
Right, but utilitarian tools come with a massive blind spot. They inherently favor the status quo.
Wait, if they're constantly trying to maximize good, shouldn't they be constantly disrupting the status quo?
You would think so. But if you apply utilitarian economic tools without deep critical reflection, you are implicitly accepting the existing distribution of wealth and resources as a valid starting point.
Oh, I see. So you are making conservative, marginal changes to improve social welfare from that baseline.
Exactly. And the goal is often a concept known as Pareto optimality.
Pareto optimality. Okay, let's apply that to our water reservoir metaphor from the beginning.
Good idea. In Pareto optimality, an allocation of resources is considered optimal if you cannot make any one person better off without making at least one other person worse off.
So if we have water left in the reservoir, and we give an extra 10 gallons to the wealthiest neighborhood, a neighborhood that already has plenty, while keeping the poorest neighborhood supply exactly the same, we have technically achieved a Pareto improvement.
Yes, someone's utility went up and nobody else's went down.
But that is infuriating. I mean, it completely ignores the fact that the starting arrangement was incredibly unjust. The poor neighborhood is still dying of thirst.
It does feel like a mathematical trick to justify inequality as long as the overall score of the system goes up, doesn't it?
Totally.
It is a profound limitation. Over the last century, economics drifted away from its roots in moral philosophy and began incorporating highly mathematical thinking modeled on physics and engineering.
It became obsessed with testing hypotheses, using massive data equations to maximize utility.
Exactly. And to make those equations work, Economics had to adopt some incredibly rigid and frankly unrealistic assumptions about human behavior.
Like assuming that people, firms, and health institutions are perfectly rational actors.
Right, and assuming they have perfect information about their choices.
And most dangerously, it assumes people are fundamentally equal, completely ignoring the messy, complicated social, cultural, and environmental variations that define real human lives.
When we talk about health needs assessment being a rational process, we are often talking about this specific, highly mathematical, somewhat artificial brand of economic rationality. And the ultimate weapon of this rationality is the QALY.
Ah, the QAY,
Yeah.
the quality adjusted life year.
Woo.
This is the common currency of health economics. We really need to break this down thoroughly because it drives so many decisions.
It really does. So a QAY is a number that indicates the size of the health gain from a specific intervention. It merges two distinct concepts, length of life and quality of life.
So to construct a QALY, economists first establish a baseline of years of life lived in perfect health. Then, they take quantitative survival data, like how many extra months or years a treatment will keep you alive.
And they merge it with softer, subjective patient perceptions of how they will actually feel and function during those years.
Right. They assign a utility value to different health states. So perfect health is a 1, death is a 0, severe disability might be, say, a 0.4.
Exactly. And there's a deep, somewhat morbid human truth embedded in this math. The core of the QLI is the trade-off. People will willingly, rationally trade length of life for quality of life.
Yeah. A patient might look at a brutal chemotherapy regimen and say, I would rather live for 2 more years with full functionality and no pain
Yeah.
than live for 5 more years if those 5 years are spent bedridden, constantly nauseous, and in agony.
That trade-off is the foundational assumption of cost-utility analysis.
Kind of makes me think of buying a used car.
Oh, how so?
Well, when you buy a car, you don't just care about the odometer. You don't just care about the maximum number of miles the engine will theoretically run before it explodes. That's the length of life.
Okay, I see where you're going.
You care about the experience of driving it. Does the air conditioning work? Is the suspension completely shot? Does the transmission slip? That is the quality of life.
Right.
So a car that will run for another 100,000 miles, but has no AC, broken seats, and shakes violently at highway speeds, has a very low quality adjusted mileage.
Yes.
As a buyer, you might gladly pay the same price for a car that will only last 60,000 miles, but provides a smooth, comfortable, reliable ride the entire time.
That analogy maps perfectly onto health interventions. The QALY allows economists to evaluate wildly different interventions, like a hip replacement versus a new asthma inhaler versus a leukemia drug using a single standardized currency.
So they use cost-utility analysis to look at the ratio of marginal benefit to marginal cost across all these competing programs.
Exactly. The goal is to maximize the overall health status of the entire population within the strict limits of the annual budget.
But there is a fatal flaw here, isn't there? A massive blind spot in the cost-utility framework when we apply it to public health.
Yes. The QALY is exceptionally good at assessing the cost-effectiveness of a discrete clinical intervention, like a specific surgical procedure or a new pharmaceutical drug, where the inputs and outputs are immediate and easily measurable.
But it fails spectacularly when applied to upstream primary public health prevention.
It absolutely falls apart.
Why does it fall apart so badly?
Because economic evaluation techniques are hyper-focused on immediate efficiency. They look for direct inputs leading to direct outputs. But public health is concerned with the wider determinants of health, housing, education, sanitation, systemic inequalities.
Right. Preventive interventions like a childhood nutrition program or an anti-smoking campaign often take decades to show measurable biological results.
Exactly. Furthermore, the benefits are diffuse across the entire society, not localized to a single patient in a hospital bed. This makes them incredibly difficult to quantify in a simple short-term QALY calculation.
So by focusing purely on economic efficiency, you inadvertently exclude the very systemic interventions that public health cares about most.
That's the tragic irony of it.
Which sets up an incredible tension. If health economics demands ruthless efficiency and immediate measurable outputs, but public health demands long-term fairness and systemic prevention, how do our actual health systems cope?
That is the ultimate tug-of-war between equity and efficiency. And to understand why systems struggle so much, we have to clearly define the two axes pulling against each other.
Okay, let's do that. On one side, we have equity. In the context of a health system, equity dictates that citizens have equal entitlement and equal access to the means of achieving good health, based purely on their actual health need, regardless of their ability to pay or where they live.
Right. And on the other side, we have efficiency. This is the drive to minimize the cost of producing good health while maximizing the overall benefits.
So in practical terms, this is usually about a government trying desperately to control the overall cost of the health system as a proportion of the country's gross domestic product.
Exactly. These are fundamentally competing objectives. It is vital to understand that most health systems fail to reconcile them because you simply cannot optimize both simultaneously.
It operates as a zero-sum game in policymaking.
It really does. If you push hard for absolute equity, costs spiral. If you push hard for absolute efficiency, vulnerable people lose access. And historically, when push comes to shove, governments default to prioritizing efficiency.
So how do different countries try to balance this? We see vastly different models around the world. Let's look at the two major historical archetypes, the Beveridge system and the Bismarck system.
Sure. The Beveridge system, named after William Beveridge, who designed the blueprint for the UK's National Health Service, is primarily financed by the government through general taxation.
The core principle being that healthcare is free at the point of use for everyone.
Right. Contrast that with a Bismarck-type system, named after Prince Otto von Bismarck in Germany. This model relies on multiple employer-based insurance schemes, often called sickness funds, usually combined with some taxation.
And unlike the Beveridge model where the government often owns the hospitals, Bismarck providers are frequently private entities.
Exactly. But despite these vastly different funding and ownership mechanisms, both systems eventually crash into the exact same reality: infinite demand and finite resources.
Whether you are paying through a centralized tax pool or decentralized insurance premiums, the money runs out before the needs are met.
It always does. And when the money runs out, governments panic. This leads to a phenomenon often described as a policy dash to localism, or frantic attempts to tinker with the mechanics of the system to balance the scales.
Give me an example of that.
Well, for instance, to control costs and increase efficiency, a centrally planned system might try to introduce market incentives. They might tell patients, you now have the choice to go to any hospital you want, public or private, to help drive down our long waiting lists through competition.
I mean, that sounds like a win for the patient. But there is always a hidden cost. The economic and social trade-off is that this market efficiency inevitably sacrifices equity.
Absolutely.
How does it sacrifice equity? Exactly.
Think about who actually benefits from choice. Giving people a choice of hospital only helps the demographic that has the financial means, the flexible work schedule, the health literacy, and the transportation to actually research and travel to a different provider 50 miles away.
So the vulnerable populations, those without cars, those working 3 jobs, the elderly, they cannot afford to move.
Right. They're left languishing on the original, now underfunded, longer waiting lists. The policy designed to increase efficiency directly increased inequity.
Wow. And the pendulum swings the other way too. If a health system strictly prioritizes universal access and absolute equity, insisting that every single person must get exactly what they need based purely on biological sickness, they quickly run out of money.
Because they lack the price signals of a free market to naturally throttle demand, right?
Yeah, their only mechanism to survive is to drastically narrow the range of healthcare services they actually offer. They just have to take things off the menu for everyone.
This ongoing, unsolvable friction explains why early forms of needs assessment so deeply frustrated health economists. Decades ago, early public health officials would conduct a survey, measure the massive, overwhelming size of the health problem in a city, and say to the government, look at all this sickness. We need resources allocated pro rata to fix this entire volume of disease.
And the economists looked at that and said, measuring the sheer volume of a problem gives us absolutely zero rules for how to allocate our finite budget across competing programs. You are just demanding money. You aren't looking at the actual costs and benefits of the interventions.
Exactly. So the economists executed a massive conceptual shift. They successfully redefined the very concept of need. They shifted it from meaning the total volume of sickness in a population to meaning the capacity of that population to actually benefit from a specific healthcare intervention.
Let's pause on that. Need is not how sick you are. Need is how much you can benefit from treatment. That is a profound shift.
It changed everything.
But if systems are constantly failing to balance equity and efficiency, and if economists are focused solely on capacity to benefit, perhaps our core foundational measurement of need is fundamentally flawed. Which brings us to a major turning point in our deep dive, the realization that biological morbidity fails as a metric.
Here's where it gets really interesting. We are moving from the practical and the economic into the political and philosophical.
Right. Because we have operated under the assumption that biological morbidity, how measurably physically sick someone is the best guide to their unmet need.
It seems completely intuitive, doesn't it? If patient A has a massive, measurable tumor and patient B has a minor skin condition, patient A has the greater need.
It does seem intuitive, but biological disease severity actually tells us remarkably little about an individual's quality of life or their broader social and psychological needs.
Exactly. Consider two hypothetical patients. Patient A has a relatively minor physical ailment, perhaps a mild chronic tremor in their hands. Biologically, it is not life-threatening.
But what if patient A is a concert pianist? That minor biological ailment completely destroys their livelihood, their identity, and their ability to function socially. Their subjective experience of need is catastrophic.
Yes. Meanwhile, patient B might have a severe, chronic, highly measurable biological illness, perhaps advanced diabetes or a severe cardiac condition. But patient B has an incredibly robust social support network, extensive financial resources, highly developed coping mechanisms, and a flexible job.
So despite the severe pathology, their actual quality of life remains excellent.
Exactly. If a health system only measures the objective biological pathology, it will drastically misallocate its resources. It will pour money into patient B while ignoring the catastrophic life collapse of patient A.
So the subjective lived experience of illness profoundly dictates the true expression of need.
And stepping back from the individual level to look at the entire population reveals the most vexing, enduring problem in all of public health: the health gradient.
The health gradient. This is the undeniable reality that health experiences and outcomes are not distributed randomly across a population. They strictly, predictably follow social position.
Right. The richer you are, the longer you live. And not only do you live longer, but you spend a higher proportion of those years in good health.
And this isn't just a quirk of one specific country. This gradient is structural. It exists in the market-driven, hyper-capitalist system of the United States, and it exists just as stubbornly in the tax-funded, universally free beverage system of the United Kingdom.
It is a fundamental feature of contemporary societies. It is not just about the billionaires versus the destitute. Every single step down the socioeconomic ladder corresponds to a measurable step down in average health outcomes.
So the upper middle class is slightly less healthy than the upper class. The middle class is less healthy than the upper middle class, and so on all the way down.
Exactly. Now, when policymakers try to tackle this, they often fall into a trap regarding how they define the problem. We need to distinguish between a health gaps approach and a health gradients approach.
This distinction dictates entire national health strategies. A health gaps approach focuses purely on the difference between the absolute worst off, most marginalized group in society and everybody else.
It implicitly assumes that everyone who isn't at the very rock bottom is essentially doing fine.
So under a gaps approach, the policy solution is highly targeted. You take all your public health resources and pour them exclusively into the poorest zip codes or the most disadvantaged demographics to pull them up to the average.
But the health grading approach recognizes the reality we just discussed. The penalty of health inequity affects the entire social hierarchy, not just the bottom. The middle income earner is suffering a health penalty compared to the high income earner.
Which leads to a fascinating policy paradox. If a government only targets the absolute bottom using the gaps approach, they will actually fail to impact the wider systemic social determinants of health that are silently degrading the health of the vast majority of the population.
This was the core revolutionary finding of the Marmot reviews, led by Sir Michael Marmot. If you only treat the most deeply disadvantaged, the systemic, society-wide inequities remain completely untouched. The health needs of the majority are ignored.
So what was the solution Marmot proposed?
A concept called proportionate universalism.
Proportionate universalism. Let's break down how that actually works in practice. It means you implement public health policies that improve health for all socioeconomic groups, from the very top to the very bottom.
But, and this is the vital mechanism, you implement them at a rate of improvement that increases at each step down the ladder. You require a differential rate of gain.
Right. The greatest focus and the heaviest resourcing still go to the poorest, but you do not exclude the rest of the gradient.
Because the root causes of inequity aren't just found in the individual choices of the poor. They are embedded in the systematic differences in life, chances, education, and environments across the entire society.
It is a massive paradigm shift, but it forces us to confront a really uncomfortable philosophical question. The gradient shows us that health differences exist literally everywhere, at every level of society. But are those differences inherently unfair?
Well, to answer that, we rely on the World Health Organization's conceptual framework, which draws a strict critical boundary between health inequality and health inequity.
People use these terms interchangeably all the time, but they mean entirely different things in public health. Health inequality refers to differences in health status that are unavoidable and unpreventable. They are a fact of nature.
Right. They are based on genetics, biology, or the natural aging process. You cannot prevent humans from aging, so the fact that 80-year-olds have higher rates of joint pain than 20-year-olds is a health inequality. It is unequal, but it is not inherently unjust.
Health inequity, however, refers to differences that are unfair, avoidable, and generated by human action and societal structures.
If an 80-year-old in a wealthy neighborhood has a life expectancy 5 years longer than an 80-year-old in a poor neighborhood because of historical redlining, pollution exposure, and lack of transit to grocery stores, that is an inequity.
Inequities are not products of nature. They are produced socially, economically, and politically, and therefore they are theoretically modifiable. We can choose to fix them.
So, if inequities are caused by the way we organize society, what is the solution? Do we just use the tax system to continuously redistribute resources in healthcare until everyone achieves the exact same health outcomes? Is that what justice looks like?
The philosopher Elizabeth Anderson offers a blistering, profound critique of that exact idea. She strongly warns against relying on a purely distributional concept of justice.
Her metaphor for this is incredible. She argues that focusing purely on rearranging healthcare resources to try and make the patterning of health outcomes more equitable is like moving deck chairs around on the deck of the Titanic after she hit the iceberg.
It perfectly captures the futility of the approach, the distributional approach to justice, the idea that the state's only job is to compensate people for bad luck or poor genetic endowments by just handing out medical resources. This is the root of the problem entirely.
Right. It doesn't matter how fairly you distribute the lifeboats or the deck chairs if the ship of society itself is structurally designed to sink the people at the bottom.
So what is the alternative to just distributing stuff? She argues for what is called relational justice.
Yes, Anderson, along with thinkers like Thomas Pogge, argue that justice isn't about giving everyone the exact same volume of resources. It is about the justness of the relations between people. It is fundamentally about ending oppression and structural violence.
Pugh makes a really aggressive argument here. He says that the global economic order itself, our trade laws, our intellectual property regimes for pharmaceuticals, our labor systems actively generates ill health and poverty.
Therefore, institutions shouldn't just be patting themselves on the back for distributing medicine fairly. They have a moral baseline duty to stop causing the harm in the first place.
Anderson argues that our goal shouldn't be a society obsessed with compensating people for bad luck. Our goal should be creating a community where people exist in equality with one another, free from domination, where the relationships are just.
Which perfectly tees up what we can call the Dworkin dilemma. The philosopher Ronald Dworkin introduces a highly controversial, intensely debated distinction regarding this idea of luck and who deserves resources.
Dworkin separates the misfortunes of life into two categories: root bad luck and optional bad luck.
Let's explore this. Brute bad luck is a circumstance completely beyond your control. You are struck by lightning. You are born with a genetic heart defect. You develop a rare autoimmune disease.
Almost everyone agrees that society and the health system has a moral duty to pool resources and help you.
But optional bad luck involves some degree of calculated risk, personal choice, and culpability.
So let me push back on this, because this is where public health gets genuinely uncomfortable. What if a patient requires a massive multi-million-dollar liver transplant, but they need it entirely because they have maintained a severe daily habit of heavy drinking for 40 years?
Under Dworkin's framework, that is optional bad luck. They made choices, they took risks.
Should the publicly funded, universally taxed health system prioritize them for a scarce organ or pay for their care over someone whose liver failed due to brute bad luck?
You have just highlighted exactly how need stops being a sterile, objective medical calculation and transforms into a deeply moral, value-laden political judgment. Does the state have a duty to deal with optional bad luck?
If we strictly follow Dworkin, the state has a duty to compensate for brute bad luck. But society might not owe you compensation for optional bad luck. where your own culpability is clearly involved. It sounds logically rigorous.
But it's incredibly dangerous. Who gets to decide what is truly optional? If we look at the social gradient we discussed earlier, we know that behaviors like smoking, heavy drinking, and poor diet are heavily concentrated in lower socioeconomic groups.
How much of addiction is a pure, isolated, rational choice? And how much is a direct product of the crushing social structures, the stress, the targeted advertising, and the trauma a person was born into?
That is the exact trap of Dworkin's dilemma, and it exposes the fatal limitation of viewing health through a purely individualistic lens. If you define every poor health outcome as optional bad luck, you give the state a convenient excuse to abandon the most vulnerable people under the guise of personal responsibility.
Which means we need a better framework. If standard utilitarian health needs assessment fails to capture relational justice, and if Dworkin's focus on individual luck leads to victim blaming, what is the alternative? How do we assess what a population needs without falling into these traps?
We have to challenge the very foundation of modern medicine, the pathogenic paradigm. For centuries, since the advent of germ theory, medicine has focused almost exclusively on the isolated individual.
We hunt for the specific invading pathogen, we sequence the individual genetic code, we measure the individual's blood pressure in a sterile clinical room.
While that approach has obviously given us miraculous medical advances, antibiotics, vaccines, targeted therapies, it has a dark side. It inherently dehumanizes people. We reduce complex human beings to a single subhuman characteristic, a mutated gene, a tumor diameter, a BMI, or an economic QALY score.
And worse, this pathogenic focus completely ignores the web of human relationships that actually define what a human life is.
To truly understand health inequities and to assess need accurately, we must understand the dynamic interaction between agency and structure. This is a vital concept developed by the social theorist Anthony Giddens.
Agency versus structure. Let's define the terms. Agency means that we are all unique, thinking individuals capable of making our own motivated choices. We have free will.
Yes. But structure refers to the massive invisible web of human relationships, economic institutions, cultural norms, and physical environments that we constantly operate within. That structure either severely constrains or actively facilitates our individual agency.
So, returning to our liver transplant example, you cannot possibly understand or judge a person's individual health behavior, their agency, their choice to drink heavily, without simultaneously understanding the social structure that made those choices either feel inevitable as a coping mechanism or impossible to escape. Structure shapes agency.
And this realization brings us to one of the most important intellectual leaps in modern public health, the work of Amartya Sen. Sen introduces what is widely considered a seminal paradigm shift capability theory.
Sen argues that our entire obsession with resource distribution, the utilitarian focus of standard health economics, the fighting over who gets the QALYs, is fundamentally flawed. Resources are not ends in themselves. A hospital bed is not an end. A pill is not an end. They are just a means to an end.
So if resources are just the means, what is the actual end goal of a health system?
Capabilities. Sen says the core focus of justice must be on what people are effectively able to do and be. Do they have the actual freedom and the real opportunity to achieve the things they value in their lives?
Exactly. When you apply Sen's capability theory to public health, it changes the entire orientation of the system. Instead of viewing a patient as a biological deficit that needs to be plugged with a specific medical resource, health systems must respect and engage with the patient's life world.
Their life world. That is a beautiful concept.
It means acknowledging the complex material, social, and psychological realities they inhabit. A health system built on capability theory doesn't just hand out insulin and consider the job done. It must help build resilience, coping mechanisms, and social skills, especially focusing on early childhood development so that people actually have the capability to manage their own environments, navigate stressors, and maintain their health autonomously.
But what happens if a health system ignores this? What if a government says, capability theory sounds nice, but we have a budget deficit? We are going to organize our health services solely around that ruthless economic efficiency we talked about earlier. We are going to maximize throughput and minimize costs.
Then the system itself becomes pathogenic. It ends up alienating and de-skilling the very patients it is supposed to help. Think about a highly efficient, hyper-rationalized modern clinic. The patient is shuffled through as quickly as possible. They are not listened to, they are processed. The doctor looks at the screen, not the patient.
If the system treats you like a widget on an assembly line just to maximize its own utilitarian metrics, it strips you of your agency. It actively decreases your capabilities.
So, by chasing pure mathematical efficiency, they don't solve health inequities. They become an active structural part of the problem. They make the inequities worse by severing the human relationships that actually maintain health.
Sin argues that justice is not a static mathematical state of perfect resource allocation that you can achieve through an algorithm. Justice is an iterative, dynamic, ongoing process of reducing injustice through respectful human relationships and empowering structures.
Which perfectly leads into something we should consider moving forward.
Yes, what does this all mean for the future of how we assess and respond to health needs? We have covered the strict epidemiology, the cold math of economics, and the deep philosophy of justice. And I want to leave you, the listener, with a final provocative thought that builds on what we've explored today.
Okay, lay it on us.
If Amartya Sen is right, if true health justice is about expanding human capabilities and respecting the complex webs of human relationships, rather than just distributing resources with utilitarian efficiency, think about the current explosion of artificial intelligence and algorithmic telemedicine in healthcare.
The drive toward AI is the ultimate manifestation of the efficiency paradigm. It is the pinnacle of utilitarian logic applied to medicine.
Exactly. We are rapidly building systems designed to triage patients via algorithm, to diagnose pathology via machine learning, to allocate hospital beds and resources with perfect mathematical rationality. The burning question is, will replacing messy, expensive human relationships in healthcare with highly efficient, perfectly rational algorithms actually increase our health equity?
Or will it sever the very human structures that give us the capability to thrive in the first place?
Are we, in our pursuit of perfect health economics, accidentally building the ultimate Bentham panopticon?
That is the defining question for the next generation of public health leaders to consider as these technologies roll out. The tools of assessment are changing, but the moral weight of the decisions remains exactly the same.
Something to seriously mull over. Now, to anchor these complex frameworks we've discussed today, we are going to transition into our rapid single best answer recall prompts. Listeners, I will ask the question and pause for a beat. Try to formulate the answer in your head before our expert gives the definitive response and points you back to the specific conceptual area for review.
Let's begin the recall.
Question 1. In the practical epidemiological approach to health needs assessment, why is defining the precise denominator population absolutely essential? Think about it for a second.
Right, so the answer is that without a clearly defined denominator population, you cannot accurately calculate or interpret fundamental measures like incidence and prevalence rates. Your data lacks the necessary context to determine the true scale of the problem. You can review this under the Epidemiological Health Needs Assessment section.
Awesome. Question 2. In the realm of health economics, what two distinct variables are merged to construct a quality-adjusted life year, or QALY? I'll give you a moment.
A QAY combines quantitative estimates of life years saved by an intervention with subjective qualitative values assigned to the utility or quality of those specific resulting health states. You can review this under Health Economics and Needs Assessment.
Great. Question 3. When organizing a public health system, what fundamental tension defines the equity-efficiency trade-off? Take a beat to think.
It is the inherent inability to simultaneously optimize equal universal access to care based strictly on need, which is equity, and the strict minimization of systemic costs to maximize overall health benefits, which is efficiency. This tension is central to health systems and the equity-efficiency trade-off.
Moving on to question 4. According to the Marmot reviews, what is the fatal limitation of implementing a health gaps policy approach that only targets the absolute most disadvantaged groups in society? Think on that.
A purely gaps-focused approach fails to impact the underlying systemic social determinants that exert a malign influence across the entire social gradient, thereby ignoring the health penalties suffered by the majority of the population. Refer to the Patterning of Health Differences section for more.
Question 5. How does the World Health Organization conceptually differentiate between a health inequality and a health inequity? Take a second.
Inequalities are unavoidable, natural variations based on factors like genetics or age, whereas inequities are unfair, avoidable differences that are actively generated by human actions, policies, and social systems. This distinction is explored in the shift from health inequality to health equity.
And our final question, question 6. In Amartya Sen's capability theory, what should be the primary end role of justice in a health system, as opposed to the standard utilitarian focus on fairly distributing resources? I'll pause.
The goal should be expanding the freedom and real opportunity individuals have to effectively achieve the things they have reason to value, building their resilience and agency rather than simply treating them as biological deficits. This is detailed in the Philosophical Reflections on Needs section.
And that brings our deep dive full circle. The next time you are faced with a scarce resource, whether it's an annual hospital budget, access to a groundbreaking new technology, or a single reservoir of water in a drought-stricken city, remember that the math is never just math. Every calculation is a moral choice about who we value, how we choose to live together, and what capabilities we owe to one another. Thanks for taking this deep dive with us.